Morning, Hannah. Oh, all the team. So just a few reminders. One is when I'm sharing my slides, I cannot see the chat box. The chat box is very, very active. So if you guys can help answer questions there. And then just so you know, I added a few slides at the end of the presentation that I will cover. So don't worry about those. I'm going to let everyone in.
Okay.
Letting everyone.
It won't allow me to make her co-host, so
Oh, okay. I got it. Okay. Good morning, everyone. So happy to see you here. Let's see. I'm going to go ahead and get started and I will share my slides. So this is the um, ninth session within 12 sessions of the Foundations of Critical Care. And let me see. Here we go. Okay, how do those slides look? Okay, you can see them? Yeah, great.
Yep.
Okay.
they look great.
Good.
Yeah, wonderful. Okay, so welcome everyone. This is session 9 of the Foundations of Critical Care webinar series. We're very excited to have you all. Today, we're going to talk about time critical management of hypertension. This is a case-based discussion. We have panelists from all over the world. I'm very excited to have lots of friends with me today. We will have Dr. Rachel Kimani. She's from Kenya. She's going to be a little bit delayed this morning. The co-host is Dr. Andrea Komisky. She's the co-PI on this project. She's with me at Stanford University in California. Dr. Freddie Ariza is a good friend of mine from Colombia. We're very excited to have him. He's an anesthesiologist. Dr. Hans Garcia, also an anesthesiologist in Colombia. We have a very nice Latin American presence on our webinar today. Dr. Hans is also an expert in cardiothoracic and cardiovascular anesthesia, so very happy to have him. Dr. Hannah Kirsch is a neurologist and intensivist at Stanford University, so very happy to have her weigh in on some of the neurologic effects from hypertensive emergencies. Dr. Sebastian Mohar is also an anesthesiologist with expertise in liver transplantation and very expert at managing hypertension as well. So very excited to have this group of panelists today from all over the world. We want to remind everyone that this is a learning environment. We want to keep it respectful. So we want people to feel safe to learn here. If you have a comment to make in the comment or chat box, please do so kindly and with respect for others. We all come from different backgrounds. We all have different levels of training. So be respectful in your communications to others. At the bottom of your screen, you will see the chat box. We encourage you to introduce yourselves there. So give us your name and what your role is in your hospital and in what country perhaps that you're from. But you'll also see at the bottom of your screen the Q&A button. That's for you to ask the panelist questions. So if you have a question specifically for one panelist or about one topic, feel free to put that in the Q&A. As we go along, the panelists will try to answer your questions, and if we have time at the end, we will also do some Q&A there. You're encouraged to turn on your video and capture your face or the room that you're in if you have the bandwidth. This session is being recorded, so your attendance is your consent to being recorded. We will also, at the end, post this recording as well as all of the slides on our Learning Resource Center, and we are being live streamed now on YouTube channel. So some people are joining us on the YouTube channel right now. There's also a closed caption button at the bottom of your screen. This will allow you to see the words that are spoken, so may be helpful for those for whom English is a second language. I mentioned the Learning Resource Center. You can scan this QR code to get access to the Learning Resource Center. This is an online school and platform. All of our webinars and all of our slides are on this platform. It's free, it's open access to anyone. In addition to the Foundations of Critical Care course, we have several other courses regarding anesthesia and critical care. Everything is free, everything is open access. Feel free to share it with others. Again, we're being live streamed on YouTube, as I mentioned. This is our YouTube channel. You can scan that QR code to share that channel with others. Everybody wants a certificate after these sessions. So just know that if you registered for this session and entered an email address, you will automatically receive email notification after the webinar if you attend the full session. You will get CME or CPD credits for attending this session. Please be patient. Give us up to 5 days to send out that email to you. If you follow the instructions in the email, you will be able to access that certificate of completion. And if you fill out the information on the CME website, you will also get CME credits from Stanford University. Okay, and with that, thank you so much. I'm going to switch now to the webinar slides. And we will get started. Wonderful. So you can see my slides, Andrea? Yes, great. Okay, so today, again, we're going to have a case-based discussion. We have a global perspective because we have panelists from across the globe, and we have all of you that can share your comments in the chat box and ask your questions. The time-critical management of hypertension, also described as hypertensive emergencies. So by the end of this session, we hope that all of you are able to identify and manage hypertensive emergencies and feel more confident in doing so, regardless of your clinical setting and regardless of the resources available to you. We'll integrate perspectives from diverse health systems and focus on evidence-based and adaptable approaches. So we want to start by understanding the global burden of hypertensive disease and hypertensive emergencies. We want to be able to recognize the clinical signs and diagnostic criteria for hypertensive emergency. And we want to apply case-based reasoning and acute management in varied settings. We hope to also discuss and anticipate and avoid the potential long-term sequelae or complications from hypertensive emergencies. So those are our learning objectives for this session. So let's begin with some definitions and classifications. We'll start with hypertensive urgency. So we want to be able to distinguish hypertensive urgency versus emergency. Hypertensive urgency occurs in patients with severe elevations of their blood pressure. That is defined as a systolic blood pressure over 180 millimeters of mercury or a diastolic blood pressure greater than 120 millimeters of mercury. We will repeat that several times, so you'll know that definition of severe hypertension. However, these patients with hypertensive urgency are not symptomatic. They don't have evidence of acute end organ damage. So hypertensive urgency needs treatment, but it can occur over hours to days. It's not an emergency where it has to occur over minutes to hours. Sometimes people with hypertensive urgency can have a headache, but for the most part, they're asymptomatic. So these patients can be managed in an outpatient setting. You can give them medications. You can discharge them from the hospital. Hypertensive urgency is very common because patients sometimes miss their medications or they run out of their medications or they take them at the wrong time. So hypertensive urgency is very, very common. So it's important to recognize you can treat that a little bit more slowly. We see this very often in the perioperative setting. There's several anesthesiologists on this call. So sometimes we see hypertensive urgency when patients present for surgery because sometimes they forget to take their medications or they're instructed inappropriately not to take their medications. Um, Hypertensive emergency is different in that you have the severe high blood pressure, but also you have life-threatening or acute end organ damage. So again, it's systolic blood pressure over 180 or diastolic blood pressure over 120. And these patients are usually experiencing signs or symptoms from their hypertension. So they can have lots of different end organ damage, which we'll discuss a bit more. These patients require immediate treatment, so they need to be treated within minutes to hours, and they often require medications that are IV through either IV push or IV infusion. So we want to discuss this a little bit more. Hypertensive urgency, again, systolic blood pressure 180, diastolic 120. Urgent management, but it can be done in hours to days, and they have the high blood pressure, but they do not have symptoms. Hypertensive emergency, they have the high blood pressure and they have signs and symptoms of acute end organ damage. This needs immediate treatment, so we're talking about minutes to hours. Let's talk a little bit more about the acute end organ damage. What is that? How do we recognize that in our patients? It's important to recognize that very high blood pressure can affect just about any organ, but the ones that we see affected most often include our neurologic systems, cardiovascular systems, and renal systems. So for cerebrovascular, you can have encephalopathy, confusion, dizziness, sometimes seizures. You can also have hemorrhage. You can have intracerebral hemorrhage, or you can have a subarachnoid hemorrhage. You can also have acute ischemic strokes in the setting of this hypertensive emergency. The cardiovascular system is also affected often, and you can have bleeding really anywhere, but one of the feared complications is aortic dissection. You can have heart failure, you can have heart attacks, etc. And then also we had a whole session previously on the critical care management of renal diseases or acute renal failure. So the kidneys are also often affected with hypertensive emergency. So really important for us to understand that the acute end organ damage can occur in any organ, but is most commonly a neurologic cardio or a cardiovascular problem or a renal problem. Dr. Komisky.
Yes, so the reason that we're presenting on this today is because hypertension has a very large global impact. Hypertension contributes to millions of deaths annually in low and middle income countries. Limited access to care, poor follow-up, and late presentation increase the risk of hypertensive crises. Whereas in high-income countries, despite the access, lifestyle factors contribute to chronic hypertension throughout the population. And according to the WHO, 1.28 billion, and I said billion with a B, adults aged 30 to 79 years worldwide have a diagnosis of hypertension. So something that is significant for our patients. Two-thirds are living in low and middle income countries, while 46% of adults in hypertension are unaware that they actually have the condition. So have not been diagnosed or they have no symptoms of it. Frequently, hypertension will be considered the silent killer because a lot of people don't even know their blood pressure is as high as it is. And less than half of adults are diagnosed and treated, and only 1 in 5 adults, so 21% with hypertension, have it under control. So very significant for the population that we're dealing with.
Okay, guys, let's introduce our case for today. This is Rodrigo. Rodrigo is 45 years old, and he was admitted to the emergency department with a severe headache and confusion. His blood pressure is 220 over 130 millimeters of mercury, dangerously high, and he has no known history of hypertension. We'll follow his course through the session. Next.
So we want to talk about the approach to the clinical assessment of these patients. I think Dr. Sebastian, do you have this slide? Or this is, oh no, okay, this is me.
Yeah, I'll jump in.
Okay, thank you.
So in case of in any of the emergencies, you always have to have a very stepwise approach to these patients when you start thinking about this or having patients like Rodrigo, as Freddie was mentioning. Well, first, in an emergency, you always have to start with your ABCs, so airway, breathing, and circulation. Given his confusion, a focused neurological exam is essential. So that's one of the first steps that you have to take into consideration. And since severe hypertension can affect any organ system, a systematic approach is always helpful. Additionally, a diagnostic testing can yield helpful information to guide treatment and management. And of course, these diagnostic evaluation will change depending on the resources you have. But let's think of what are the steps or what you should have in your mental algorithm at the moment that you approach patients like Rodrigo. So why don't we'll give you a couple of seconds for you to answer. What are some examples from everybody so you can write in the chat box, what are the examples of neurological signs and symptoms that can be seen during a hypertension emergency, like the ones that we have with Rodrigo?
So this is for you, the learners. Throughout this webinar, we will have some questions and some time for you to interact. So we're going to give you 30 seconds to type your answers in the chat box. I'm keeping time, don't worry.
Okay.
Signs and symptoms of hypertensive emergency. I already gave you some earlier, so hopefully you were paying attention to this. Okay, I think that's good, Dr. Sebastian.
So as I can see, all of you guys are participating. Confusion is one of the main parts, and as we can see with Rodrigo, is one of the things that came up to the hospital. But there are also other signs that we have to take into consideration. So a severe headache always has to ring a bell. Stupor, agitation. If there's any alteration with your vision, blurred vision, or having any alteration with what the patient is seeing. Seizures is also a common symptom or sign that you can see in hypertensive emergencies. And also some patients may present with nausea, vomiting, and this can be associated with an increased intracranial pressure. Some of you guys have also talked about some hypertensive retinopathy, which is also an important thing that we can see and that we will be talking about in the following slides. So I think this is like what you've been saying in the chat is really helpful, and I think you guys are in the right direction. So we jump to the next slide, and we'll give another 30 seconds. What can you see if you do suspect of a hypertensive emergency? What can you possibly see on a fundoscopic exam? So what are the traditional signs or that you would be able to see in the retinal exam? Okay, yeah, papillary edema. You're taking time, right, Anna?
Yes.
Okay.
I've got it. Thank you. But it sounds like they already know the answers, isn't it?
Yeah. Pretty
We'll
much.
go ahead and skip ahead then. So
yeah,
for all of our way too smart learners.
exactly. So yeah, exactly what whoever is reading the chat pretty much is reading the slide. So you can see one of the most characteristics and that we all think about in the moment that we have an hypertensive emergency, the papillary edema, which is a blurring of the optic disc that you can see in the fundoscopic exam. But there are also other signs that you can see as flame hemorrhages, as you can see your image on your left side of the screen. There are those you see the bleeding and it kind of creates a flame. That's why it's called flame hemorrhages. There's also exudates, which can be seen as cotton wool spots. So the most classic one is the papillary edema. That's the one that we usually learn from. Although these type of fundoscopic exam, it's not as simple as do, especially in a confused patients. But if you're able to see these signs, it gives you and it helps you guide to this already has it's having an effect or an end organ damage, so it's not an emergency and it's not an urgency anymore. It's becoming an emergency, which is what we have to keep in mind during the slides.
I think your point about having a confused patient is really a good one clinically. So if your patient is unable to cooperate with the fundoscopic exam, it
Yeah,
might be okay to skip it if it's going to endanger the patient. But if you're able to do it, then you can see some of these signs and symptoms.
exactly. So now, going ahead from the signs and symptoms, if you do have neurological findings, what is the concern or your main concern of having these neurological findings? Sorry. Again, we'll give some time for you guys to answer in the chat box.
Ten more
Yeah,
seconds.
perfect.
I can't see the chat box, but I'm sure they're getting it right.
No, they're getting it. Yeah, they're getting exactly. It's as
Okay.
if they had the slides before. Everybody's
Oh,
getting
so
it.
the slides are actually posted on the Learning Resource Center ahead of
Okay,
time. So it is possible that there's some people that have the slides already, but we try to do
perfect.
that so that people can read ahead if they want, and then they would be prepared to ask questions if they have questions. But we can go ahead
That's
and
great.
talk about the focal neurologic findings.
Yeah, so like I think that's an important thing to keep in mind when you're seeing these patients, the difference between focal and non-focal neurological findings. When we're talking about a focal neurological finding or deficit, it is a problem with a specific nerve, the spinal cord, or brain function, but it has to be specific to that. That specific location, such as the ones you've already mentioned in the chat box or we've been talking about, it can only affect one side of the face or maybe one arm, or it can even be as small as just affecting a tiny part of the tongue, but that's enough for us to be able to define that it's a focal neurological deficit. These can be seen as you're writing, as I'm speaking, in hemorrhagic or ischemic strokes. So it talks about the localization or where that damage is being done and helps you map out where to suspect that the damage in the central nervous system is happening. Hemorrhagic stroke is caused and associated with extremely high blood pressures, but sometimes extreme hypertension can be a reaction to ongoing ischemic stroke. So it doesn't mean that it's either one or the other. They can sometimes be together. Ischemic stroke can cause a hypertensive emergency and cause a hemorrhagic stroke. So, and when we're talking about a non-focal, it's more that it's not specific to a certain area of the brain. It's more a general loss of consciousness, maybe confusion, agitation. And this is a non-focal finding, and it doesn't help us map out, but it is something that we have to be very alert about. It's also talking about the brain suffering.
I
Yeah,
think some common things, and I would welcome Dr. Kirsch to weigh in
yeah.
here. And she made the excellent point that it can, you can have a hemorrhagic stroke that's affecting just one part of the brain, and that can cause um, the focal neurologic symptoms. But if you have an ischemic stroke, then you can also have incredibly high blood pressure. But I think for the non-focal neurologic signs, that would be maybe considered something that we see often, which would be like increased intracranial pressure would kind of have a more global neurologic sequelae.
Yep.
We can also sometimes see what we call PRES, which is posterior reversible encephalopathy syndrome, which can be focal or non-focal and can be caused by hypertension. So sometimes you don't see stroke at all.
Yeah, that's a great point. We see that we see that not infrequently in our setting for sure. Yeah.
Okay, guys. Bad news for you. Rodrigo refers severe headache and confusion at the admission, but additionally, he to his dangerously high blood pressure, he is now complaining chest pain and tiredness. Rodrigo is worsening.
All right. So I think this is also another important approach that we need to have for these patients, not only the neurological or the focal deficits that we were talking beforehand, but also all the other symptoms that can be associated with these hypertensive emergencies. So when we're talking about cardiovascular and cardiothoracic complications, we can divide it into two big groups. We're talking about cardiovascular when the patient refers, as Rodrigo said, some chest pain or back pain or chest discomfort or any of those variations, we have to be thinking that it might be associated with myocardial ischemia or infarction, or it can even be an aortic dissection. But also within the thoracic area can be associated if the patient has dyspnea, although dyspnea can be associated with the myocardial ischemia or infarction as well. There are other scenarios that can also be contributing to these type of signs, which can be associated with a heart failure or a pulmonary edema, which can be secondary to the heart failure as well. So just having in mind that it's a global picture that we're seeing, not only the neurological, but we also have to go to the cardiothoracic and cardiovascular systems to see what is being affected in that area as well. It's important to mention, like, these sometimes we think that this dyspnea or the chest discomfort can be associated with anxiety, and it is caused, and it is associated with this, but it's important to treat it as a diagnosis of exclusion. Before, you have to discard everything that it's not myocardial ischemia or the dissection, that you don't have any heart problems or heart failures before you jump into anxiety. But it is possible that anxiety is contributing to these signs and symptoms, especially if a patient is confused or has this or is in a hospital.
That's a really good point. I think, the chest tightness is definitely something that we associate with anxiety. But for example, if the patient has pulmonary edema or, other signs and symptoms, you cannot just say it's anxiety. You have to make sure that it's not something serious. Yeah, that's a great point.
So in this part of the case, we need to complete our evaluation with the lab test. We need to consider that the clinic, the symptoms, all the patient is telling us is really important, but we need to complete a comprehensive evaluation. So for this moment, what do you consider to evaluate in Rodrigo?
So
please, in the chat.
Yeah, we can put it in the chat, and I'll give you 30 seconds to put your answers there. Remembering all the different systems and organs that can be affected by hypertensive emergency. It's important to order the right tests to help us manage these patients. Okay, that's 30 seconds, Dr. Hans.
Okay, what we get? So all the answers are really good. And we want to consider that the fluid body count is really important. We need to evaluate how are the platelets, what is the hemoglobin in our patient, how is the metabolic profile, the renal function, the troponins. We have to consider all that is happening with the patient in this kind of emergency. And if we are consider the end organ damage, we don't need a full lab test. We need to focus on what we really need. And what other image do you need for complete evaluation in our patient? Please, the next slide, Anna.
Can I ask a question before we move?
Sure, absolutely, absolutely.
So I put up here the complete blood count, but also FBC. In certain settings, like our setting, we say a CBC or complete blood count. What do you call it in your setting? Is it a full blood count or a complete blood count?
It's full. It's full blood count.
Yeah, that's my experience in East Africa as well. It's a full blood count, not complete. So just a small difference there. And then the metabolic profile, the complete metabolic or full metabolic profile. What are some of the abnormalities we're looking for? We have listed definitely the electrolytes, but also the urea nitrogen, the glomerular filtration rate, and the creatinine. If you remember earlier, we talked about the most common end organ or acute end organ damage, and we talked about neurologic, cardiovascular, cardiothoracic, but also renal. So we already had a whole webinar session on acute renal failure, but these are some of the electrolytes that are some of the lab tests that will help us evaluate our kidney function. And then troponin is an obvious one to check as well. Okay, thank you.
So please let us know in the chat, what do you think another image that you need for complete evaluation of the patient? Here you see the X-ray. What else? And I think that is the same with the lab test. We need to consider what organs could be compromised. So we really need to think ultrasound, CT, MRI. So about the ECG. The ECG is really helpful. Sometimes these kind of patients can get some myocardial infarction, some ischemia. They can appear some arrhythmias. The X-ray is going to help us looking for the pulmonary edema, what's happening with the size of the heart, or the mediastinum is wide. And this is some kind of differential diagnosis that we can have. We can have our patient with the emergency with the hypertension, and also he can be with a dissection of the aorta. So this is important to consider the point of care. The point of care is really a great tool that we can have in emergency, at the ICU, at the operating room. And we are going to find the heart evaluation, the lungs evaluation, the mediastinum. Also, we can see in the abdomen if there are free fluids that can help us with the compromise of the aortic in the abdominal area. So important, the CT MRI, because we know that the head, the brain is going to be one of the organ that can be affected by these kind of emergencies. So even in focal or no focal neurologic symptoms, we can consider that. And even if these CT or MRI are normal, we need to continue with the angiography. Angiography is going to be the gold standard to consider or to complete this kind of evaluation. Fundoscopy is also important. As an anesthesiologist, I'm not pretty good doing that kind, but we can ask for internal medicine or other colleagues that can help us to complete this kind of evaluation.
That's fair, Dr. Hans. I can't remember the last time I picked up an ophthalmoscope, frankly. Yeah. But I think it is very interesting. And sometimes in where we don't have a CT of the head or an MRI or things like that, maybe we do have an ophthalmoscope. So it's good to mention all the tools, because some places have a lot of resources and other places don't. So if you see papilledema, but you don't have a CT, maybe you can start to manage some signs of increased intracranial pressure and the hypertension. I think one interesting thing on the chest X-ray is to mention is there's several signs that, I mean, a chest X-ray has so much information and value. The kind of chronic sign that you see in someone who has hypertension over years is that they're going to have an enlarged left ventricle. So you'll see a cardiomegaly on their chest X-ray. So the heart will be greater than 50% the width of that chest X-ray. So if you see a very large heart, that could signify left ventricular hypertrophy from chronic hypertension. It could also be enlarged if you have like a congestive heart failure over years, because you get that dilation of the heart. The pulmonary edema is a kind of telltale sign of congestive heart failure. And then the widened mediastinum is something that would be very concerning. So if you don't have a CT, but you can get a chest X-ray, you have that patient with mid-sternal pain that radiates to the back, they have the hypertensive emergency, and then you see that widened mediastinum on the chest X-ray, you should be very, very concerned about aortic dissection. And so those patients are treated, we'll get into treatment soon, but those patients are treated slightly differently. And then the point of care ultrasound is also an incredible tool. And Dr. Komisky, not to put you on the side on the spotlight, but what would you see? What are some things you would look for in point of care ultrasound if you were concerned about this hypertensive emergency specific to the heart and lungs?
Yeah, so great question. I think in regards to the lungs, you would certainly see B lines throughout. So like the vertical line stretching throughout your lung fields. That'll show you pulmonary edema. And then if you're worried about the heart itself, you might see like reduced cardiac function as far as like diffuse global hypokinesis or reduced function throughout. Potentially even one area in particular that has less function, if that's like of concern, if you have like a myocardial event. But outside of the heart and lungs, you can also look for a dissection flap on your aorta if you feel confident enough in your skills. So that's another way to confirm your aortic dissection if you don't necessarily have CT imaging readily available, if your clinical suspicion is high enough. And then you can also look for papilledema with an ocular ultrasound. And so that's another way to look for papilledema if you're not as familiar with using the ophthalmoscope or you don't have it available. It's a tool to utilize and relatively low risk, low cost.
Yeah, wonderful. Dr. Kirsch, I know you are an expert in reading CTs and MRIs and made some points about whether you do or do not see abnormalities on the CT. Can you tell us a little bit more about that?
Yeah, of course. So you can absolutely have abnormalities that are not related to stroke in your neurological exam. And so it's completely plausible that you have a normal head CT and would even have a normal MRI if you're able to get it, but the patient could still be confused and in rare cases could still have focal findings, in which case you would pursue, ruling out seizure. But just recall that a normal CT does not necessarily rule out acute ischemic stroke. And so if your clinical suspicion is high for acute ischemic stroke and somebody has focal neurological deficits, you should proceed to vascular imaging. In people who are confused, you can also see things like cerebral edema and, as I mentioned, signs of PRES with edema more in the back of the brain, in which case it just gives you some more urgency, not only to lower the blood pressure, but maybe to take other measures for reducing intracranial pressure. Things as easy as sitting up the patient or maybe giving them sodium or mannitol to help bring that down while you're working on lowering the blood pressure.
Wonderful. So we'll get into a little bit more about ischemic versus hemorrhagic strokes in the coming slides. I wonder how our patient is doing. What's going on with Rodrigo?
Oh, Anna, Rodrigo was under I imagine diagnostic test, and the CT scan showed no acute hemorrhage, but mild cerebral edema. Labs show renal impairment and target organ damage, and his serum creatinine was elevated. He has a protein in his urine and left ventricle hypertrophy on electrocardiography suggests chronic hypertension. These findings confirm an hypertensive emergency.
Great. Okay. Poor Rodrigo. Hopefully we can make him better.
Wow. Yeah.
So he has high blood pressure, severe hypertension, which is again what? Systolic over 180 or diastolic over 120. And he definitely has acute end organ damage from the confusion from a neurologic standpoint, if he has pulmonary edema on his chest X-ray, and then he has this renal dysfunction. So he definitely has acute end organ involvement. So he has hypertensive emergency, certainly. What do we do next?
Great question. So now that we've made the diagnosis of hypertension and the hypertensive urgency and emergency, the next thing we want to do is try to lower the blood pressure. However, in general, lowering blood pressure too quickly or too much can also cause problems with ischemia or lack of blood flow to those areas, especially in patients who are used to chronic hypertension and their vascular beds have been adapted to high blood pressure throughout. And this is done through a right-shifted autoregulation curve, which we'll get into next. The timeline for lowering the blood pressure, the goal blood pressure, and the medication agent of choice is determined by whether the acute end organ damage is occurring in the brain, heart, or kidneys, and or a combination of the three. And so, as I was alluding to, the kidneys and brain are capable of regulating blood flow within a normal mean arterial pressure or MAP range, typically described as 60 to 160. However, in patients with chronic hypertension, as you can see in the figure, their autoregulation curve is shifted to the right. This results in the need for a higher MAP requirement to maintain the constant blood flow for the hypertensive patients. And then the true MAP target for each patient is not known exactly, but a higher MAP may be considered in patients with chronic hypertension, something to take into consideration when trying to manage them. And so the key in managing hypertensive emergency is controlled reduction in their blood pressure, which is super important. Too rapid of a drop risks the ischemia. And so trying to monitor them in an ICU level of care is ideal, but we also know that that's always not available, particularly in some low and middle income countries. Target blood pressure is not often evidence-based, but for most hypertensive emergencies, a general consensus holds that the mean arterial pressure should be reduced gradually and by approximately 10 to 20% within the first hour. And then you can reduce it a further 5 to 15% over the next 23 hours over the next day. This often results in a target blood pressure of less than 180 over less than 120 for the first hour, and then a further reduction to less than 160 over less than 110 for the next 23 hours. Rarely do you get to the less than 130 to less than 80 during that time frame, but it is certainly a lofty goal and can be attainable in the right patient. And so it says here also that the known three major exceptions to all of this are the acute phase of the ischemic stroke, which Dr. Kirsch can speak to you on more, and then also the acute aortic dissection, because you want to decrease the shearing force to that aortic flap, which is important so it doesn't extend further, and then also within your intracranial hemorrhage.
Yeah. So just to clarify, the general approach is for most patients, but if you have a patient with ischemic stroke, aortic dissection, or intracerebral hemorrhage, we manage these patients slightly differently. So it's really important to identify these three conditions and then adapt your management appropriately.
So the reason that it's important to adapt this is that if a patient is confirmed to have an ischemic stroke, then rapid lowering of the blood pressure can deprive that right-shifted brain of blood flow and worsen the ischemia. So if somebody is eligible and able to get reperfusion therapy with TPA or TNK, recall that severe uncontrolled hypertension, that blood pressure greater than 185 systolic over 115 diastolic, is actually a contraindication because the worry is that you'll have hemorrhagic conversion of that stroke with TPA or alteplase. So there are lots of antihypertensive medications that can be attempted to get the blood pressure below that level. You see here this chart from Up to Date where we list a number of options, including labetalol, clofazimine, Hydral, enalapril, and nicardipine as options to lower below that level. So if you're able to get it below 185 over 115 and give the reperfusion therapy, then ideally ICU monitoring is necessary in these patients to ensure that the BP does not increase again, because that can still risk hemorrhagic conversion of the stroke. So the recommended protocol is that the blood pressure be monitored every 15 minutes for 2 hours, then every 30 minutes for 6 hours, and every hour for 16 hours. And use those continuous options like labetalol, nicardipine, and clofazimine for treatment and titrating them as needed to keep the blood pressure lower, but again, not dropping it too low. Just you don't have to normalize it all that quickly, just keep it under the hemorrhagic stroke risk. If the diastolic pressure is uncontrolled in particular, then you can consider adding sodium nitroprusside, although in most of these patients, unlike with the cardiac issues, you're a little bit more worried about the systolic.
One small little point of maybe clarification, since we have such a global audience and panelists, is that ideally these patients would be monitored and managed in an intensive care unit. Unfortunately, even in some rural parts of the United States or Canada or high-income countries, we either don't have intensive care units or we don't have people trained in critical care to manage those intensive care units and those patients. I think another thing that's important to recognize is globally, whether it's a high-income country or a low-income country, 90% of critically ill patients are actually found outside of the intensive care unit. So even if these patients are on the wards or in the emergency room or in the recovery room after surgery, it's really important to recognize how time critical this management can be, especially in these three conditions of stroke, ischemia, stroke, hemorrhagic, and aortic dissection. So even if you do not have an intensive care unit, these patients need critical care. Critical care can be delivered anywhere. So I think it's really great, Dr. Kirsch, that you mentioned that even if you're not in the ICU, it's still ideal to monitor them every 15 minutes for 2 hours, every 30 minutes for 6 hours, and then every hour for 16 hours after you start this treatment. Or, if they decompensate during that time, that you may want to increase that monitoring of the blood pressure, even, reassessment of their physical signs and symptoms is really important. So if you don't have an intensive care unit and you don't have access to pumps and infusions, you still can use IV medications that you push and titrate, even if you don't have true ICU services in your hospital. So I just want you all to feel empowered to be able to take care of patients anywhere with any resources that are available to you, because this is life-saving. These are life-threatening disorders in these patients, and we'd love to save them all. Thank you. Sorry.
Yeah, thank you. That's a fabulous point. And I know many of you are in settings where you can even enlist family members to check blood pressures on a regular basis. These people need a lot of attention, and anybody helps. This slide is just a summary of these blood pressure goals. So before reperfusion, less than 185 over 110, and then during and after, it's less than 180 over 105 times that 24 hours. If you cannot give reperfusion, if it's contraindicated for whatever reason, either the ischemic stroke is done and the patient will not benefit from reperfusion, or reperfusion is not available, we let people run higher. We call this permissive hypertension. So typically we start treatment when the systolic is greater than 220 or the diastolic is greater than 120, and then aim for a 15% reduction over 24 hours to preserve as much of that brain tissue as possible. Using reversible medications or very short-acting ones is preferable, and titratable if you have available. And these are what the consensus guidelines suggest: labetalol, nicardipine, and clofidipine for these delicate patients in the first 24 hours.
Dr. Ariza, do you have all of these medications in all of the hospitals in Colombia? Would, for example, a hospital in a very rural area have clofidipine or nicardipine?
Not really. Only in the city areas we have all these medications, but in the rural areas it's very difficult because the pharmacotherapy options are very, very few. So for example, at many places we will have the chance to titrate with nitroglycerin or nitroprusiate these patients while they are transferred to the big hospitals. But in fact, the pharmacopoeia is very reduced.
Yeah. What about labetalol? Is that universally available in your hospitals, do you think, in Colombia? And
Yes.
Hans, you can answer as well, since you're in Colombia as well.
Yes. I don't know, but Hans can complement my answer. We have regularly in all our hospitals the protocols that has a full adherence to the steps that we had to do in these patients.
I agree. I think that it's the same as Freddy says before. In rural area, we have scarce resources, so we don't have these labetalol, esmorol. No, usually we only have metoprolol and nitros. That's it.
Interesting. Okay. I would have thought that labetalol was maybe more common than metoprolol, but maybe that's just in my rural settings in the US. Interesting. Okay. So now what are the differences in blood pressure management during acute aortic dissections?
Okay, it's completely different. We have seen how in the stroke we need to go step by step, but here we need to run. We are on the rush. But first, I think that the big problem is getting the diagnosis. And sometimes if we don't have the tools for the image, the CT, the MRI, it's going to be complicated. We have had some cases that patients get the diagnosis of myocardial infarction because they found the ST elevation on the ECG, but that can be caused in a dissection because the coronary arteries are compromised.
Right.
And these kind of patients in my hospital at the ER, they get antiplatelets, heparin, all the treatment for the coronary disease, and then we have to take this patient to the OR because of the aortic dissection. So it's a complicated case.
I would imagine heparin is not the best idea with the aortic dissections.
Absolutely. And then the platelets, clopidogrel, 300 milligrams, and the aspirin, it's complicated. We have learned from Freddie about how we can manage these coagulopathies in these patients. Okay, so the first thing in these patients, we need to consider that the aortic dissection is a surgical emergency. And when we consider this diagnosis, we need to ask, we will have the surgery room, the surgeons available, because for the type A, we use the Stanford classification, we're gonna see later. We need to operate these patients really quickly. Completely different with the patients with the dissections of the descending aorta or the abdominal aorta. And we don't found any evidence of the organ damage or any rupture. So we can treat these patients with medications at the emergency room or at the ICU better. And then we can schedule these patients for surgery, for endovascular or open surgery, whatever.
So you're saying that the patients where the aorta, it's the ascending aorta, is a different management because the coronary arteries come off of that ascending aorta. So that's where you maybe will see the coronary involvement and the signs of myocardial infarction. Is that correct?
Yes, that's right. And we can get compromised the cranial vessels, the carotids, arteries, and the aortic valve can be involved. Also, decreasing the capacity of the heart to maintain a cardiac output. So it's really complicated, the type A of this dissection. So in the physical exam, we need to evaluate, we can find some difference between the blood pressure in the right arm or the left arm because of the area of the dissection, what is happening. Sometimes we can get some patients with the dissection type I with all the aortic arch. It's going to be more complicated. The surgery has a high mortality. We have to know that to explain to the family. And also it's important to complete the neurologic evaluation because we can find this kind of weakness or neuropathy associated with this impairment of the blood supply. So for these patients, we need to complete the ECG, the X-ray, the chest X-ray, the CT, the MRI. And if we don't have the tools, as Dr. Komensky says, the POCUS, the point of care ultrasound is going to be helpful, the transthoracic evaluation. But the problem is that usually we only can see just 5 centimeters to 7 centimeters of the aortic aorta. So it's complicated. So the better tool is the transesophageal echocardiography. We can get a full evaluation of the cardiac function, the valve, if the aortic valve is compromised, what's happening with the aortic ascending aorta and the descending aorta. But it's the same with the aortic arc. We can see that part usually with the transesophageal because the bronchi, because of the air, is a limitation for the ultrasound evaluation. But if we can have the transesophageal echocardiography, we can evaluate the flap, and sometimes the flap is compromised with the aortic valve. That's going to compromise the cardiac function, as I said before. Okay.
So this image here is of a CT scan, yeah?
Yeah, here we can see the CT scan, and actually in the middle we can evaluate the flap. The flap is the area of the aorta that is compromised, and we can have 2 different lumens of blood flow. One is true, one is the false, and we can, if we don't stop or we can decrease the blood pressure, this hypertension emergency with medications, the flap is going to continue really quickly and get compromised, and we can get compromised the renal arteries, the abdominal arteries, and actually we can get dissected all the complete aorta.
So can we do a brief review of the aortic anatomy? Because I think that helps us to determine what may be involved. So we mentioned the aortic arch has the coronaries, but it also has the carotids and it has like the subclavian takeoff. So you're going to have neurologic symptoms or cardiac symptoms, or maybe a different in blood pressure of the upper extremities. And then if it's the descending aorta, you have the descending thoracic or descending abdominal aorta. And so you may have spinal cord problems, you may have kidney problems. Is that how you think about it?
Yes, it is. It is.
Okay.
So we need to evaluate in the clinic with the physical examination and with the lab test and the image to complete all the full examination of the patient with this diagnosis.
Okay. And so what's our blood pressure management goal?
So we need to decrease really quickly. Usually we start with using beta blockers. As I said, usually in Colombia, we have metoprolol, and we start to titrate 5 milligrams to complete 15 milligrams, and that's it that we can use using the metoprolol. But with labetalol or esmolol, we can titrate that dose, and we can increase, and we can evaluate each minute, 3 minutes, 5 minutes, and we can get this the control of this hypertension emergency really quickly because of the pharmacokinetics of these kind of drugs. So definitely we have to try to get esmolol or labetalol in our emergency rooms or at the ICU to get a systolic blood pressure below 100, between 100 and 120 millimeters of mercury. But we can get these with the beta blockers. We try to control the heart rate below 60, and we finally we can get this goal of the heart rate. We need to add some medications, usually vasodilators like nitroprusside. We prefer nitroprusside because nitroglycerin could be compromised coronary perfusion. So if the patient doesn't has a myocardial infarction, we prefer to titrate nitroprusside.
So you start with the heart rate first. So
we start with heart rate.
So beta blocker first, and then you go to the vasodilator, it sounds.
That's it.
Okay,
That's it.
okay.
And at the same time, we are asking for the surgical service, the availability. And if not, we need to refer this patient, because the only option that they have, especially we can see here in the left, the DBK type 1, or with the Stanford A, that is what is the classification that we use. We need to operate immediately these kind of patients. So basically, the difference between DBK and Stanford classification, for me, is more easy to use the Stanford, because we need just to get compromised the aortic, the ascending aorta, and that's it. We can catalog these patients as a type 1, and we know that all these patients are an emergency immediately. Different from type B or the DBK type 3. As I said before, we can control with medications, we can stabilize the patient at the ICU, complete all the lab tests and the image that the surgeons need. Actually, they can order for the endovascular repair the graft exactly that they need for the patient. Completely different if there is a rupture in a type 3 or Stanford B. If there is a rupture or there is a compromise of some organs like renal function, we need to operate these kind of patients immediately.
Right. Okay. So if you don't have an ICU and you recognize this, it would be really good for the patient to try to triage them or transfer them to a higher level of care if that's possible. Yeah, thank you so much. That's an excellent review of the blood pressure goals, the heart rate goals, and a review of DeBakey versus Stanford. I think it's interesting to remember at the beginning, we talked about hypertensive emergency, and Dr. Comiskey told us to have a nice, slow, gradual lowering of the blood pressure over minutes to hours. But this is one of the three very different situations. In this situation, you want to lower it as quickly as possible. So it's really good to understand.
So switching back to the brain, let's now talk about intracerebral hemorrhage as opposed to ischemic stroke. So during ICH, you want to prevent bleed expansion, manage any increased ICP that you're getting from the blood, and then any other neurological complications like hydrocephalus, seizures, or herniation. And then, of course, concurrently, you have to manage any other medical problems that could be caused by that extreme hypertension, like kidney and cardiac disease. So just note that ongoing BP elevation increases the risk of hemorrhage expansion, and that is the #1 risk for poor outcome.
May I ask you a question, Dr. Kirsch?
Yeah,
The
of course.
intracerebral hemorrhage, so a bleed into the brain associated with high blood pressure, where's the most common location that bleed will occur within the brain?
A great question. So most commonly occurs in the basal ganglia, so deep in the brain, right adjacent to the ventricles. Other very common sites include the cerebellum and the pons, which of course are, super high density areas with very high risk for herniation.
So those outcomes are sometimes poor just because of the location in which that bleed occurs, because those are very important structures in our brains. Is that true?
Exactly. And that's often regardless of the resource nature of the setting. So if we are talking about how to lower, if your systolic is between 150 and 220 millimeters mercury, then the goal is to lower to 140 millimeters mercury or below within 1 hour. However, if your systolic is higher, greater than 220, lower less than 220 immediately, but then over the next several hours, target lower than 140 to 160. And we don't know exactly what the perfect BP goal is, and there's ongoing trials that I'll touch on briefly, but just note that you don't want to lower it quite as precipitously, again, because of the risks to the kidneys, the heart, and other organs. So again, as you've been discussing, the choice of medications depends on what you have in what setting. The one thing to note is that in this specific setting, nitroglycerin and nitroprusside you should avoid because they can theoretically increase intracranial pressure. Some of us avoid hydralazine in this setting because it can theoretically increase venous pressure, especially as the medication's wearing off. But if all you have is hydralazine, it's better to lower the blood pressure in those settings. Would still avoid nitroprusside and nitroglycerin. If your patient deteriorates clinically during this period, though, then you can be more aggressive in reducing your blood pressure. So keeping that 140 to 160 in mind, this, of course, is for somebody who is okay. If they deteriorate and you're worried about increasing bleed, it is absolutely fine to evaluate that risk and lower less than 140 anyway. So there's a few really crucial trials that we've done in this setting. INTERACT-2 and ATAC-2, ATAC-ATACH2 are the most important ones. And so when we look at a post-hoc analysis of patient data, every time you reduce the systolic pressure by 10 millimeters of mercury within the first 24 hours, the odds of better functional recovery go up 10%. So 10 millimeters reduction, 10% improved odds of good functional recovery. The threshold appears to be around 120 to 130 millimeters mercury, and so there does not appear to be benefit to lowering below that, unlike in the case that we just heard. So I usually, in my patients with significant hypertension, target about 130. With INTERACT-2, we noted that intensive lowering of blood pressure did not result in improvement of the primary outcomes of death or severe disability. With intensive lowering of blood pressure, if you look at an ordinal analysis of modified Rankin scores, it improves, but specifically severe lowering of blood pressure, meaning below 130, did not improve anything. So again, what I'm trying to say with all of this is that while you should lower the blood pressure, targeting something aggressive is absolutely not necessary in these patients.
Dr. Kirsch, you work in a very high resource setting. You're at Stanford University in California in the United States. What is your agent of choice for managing the blood pressure in a patient with intracerebral hemorrhage?
So my two agents of choice are nicardipine and clofidipine. Those are basically about the same for me, unless the patient has significant pulmonary shunting, in which case I reach for clofidipine. I actually work part of the time in one of our community hospitals in which only nicardipine is available and have not seen any difference whatsoever.
Great. Thank you so much. Go ahead. Go
Oh,
ahead.
sorry. So we've already talked with the panelists about the individual drugs and availability that they have available, but this is kind of an opportunity that we like to hear from the audience about what medications that you use in your setting. And so if you could take a moment to type in the chat box so we can understand what you all are working with, that would be very helpful.
I think it would be also helpful to know what agents you would use in your tertiary care center. So if you're in the intensive care unit in your major city versus you're in a district or a rural hospital, what medications would you use? So maybe give two answers for this. And we'll give you 30 seconds for you to answer in the chat box. Dr. Garcia, how is that answer for you in your hospital where you do lots of cardiothoracic surgery versus maybe a more rural hospital?
Actually, we have all the options, and that's a pretty good thing for us in our high level of complexity for surgeries, for pathologies. We usually have all the options. The problem is in level 2 or level 1. For us, it's different. In Colombia, level 1 is the lowest level for care. So for us, level 1 and level 2 in rural areas are really with basic medications. As I said, usually you can find metoprolol in all the hospitals. For example, for arrhythmias, we don't have usually amiodarone. We only have lidocaine as an option for that. So usually with vasopressors could be the same. What do you think, Freddie?
For many of our rural places, people can opt or may usually opt for giving an oral dose of the the current antihypertensive that is taking the patient. So it's very limited, in fact, and I think that we can have high gap between high-level hospitals and rural areas. That's the truth. Yeah.
What about in Mexico, Dr. Sebastian?
Yeah, so I think the it's pretty similar to what Freddy and Hans were talking about. It depends a lot. In the high setting where I was trained, we had all the options available. But usually in the more rural setting, especially in the southern states of Mexico, you have one or two and it varies. So you have to change your algorithm constantly because the distribution of medications changes throughout the year. Usually we will always have nifedipine, which is one of the main things that we use for hypertensive emergencies. And that is usually well distributed. And as Hans was talking about, metoprolol is more available than labetalol as well. So we try to defend ourselves with those two. But many of the times we also try to, if the patient is an already known hypertensive patient, we ask him to bring their own medications or the family to bring their medications and try to use that strategy to lower their BP in the first hours to try to avoid the natural prostate that might give like a very steep decrease, and that could damage other organs as well.
Interesting. Yeah. Unfortunately, Dr. Kimani from Kenya is not able to be with us this morning, but my experience working for 17 years in Rwanda is that when you have the tertiary center, especially in the private hospital where they actually do cardiovascular and cardiothoracic surgeries, you have options like nicardipine and some of those others. But in the more rural or district hospitals, it's unpredictable. Sometimes you have medication, sometimes you don't. Sometimes you have the ability to run an infusion pump, and sometimes you don't. So it's really variable across different hospitals, even within the same country. And I would say the same for even in the United States. In our more rural hospitals, sometimes we don't have these medications. But for example, at Stanford, as Dr. Kirsch described, we have just about all of them. So very interesting. Back to you, Dr. Kaminsky. Sorry to interrupt again.
No, thank you. Looking through the chat box, it looks like hydralazine and labetalol are used quite synonymously throughout the globe, and so that's good. And so kind of getting into the table that we have listed here, this is just some of the more commonly available vasodilators that we see. The most commonly used medications in high resource settings include clofidipine and nicardipine. similar to what Dr. Kirsch is saying, where I did my residency training, we didn't even have clobidipine. I didn't know that was a drug until I came to Stanford. And so now we use it all the time. So it's very institutionally dependent. Um, Other older agents that are probably more globally available include nitroglycerin, nitroprusside, which we've talked about briefly with the panelists and some of the participants. And it's important to understand their adverse side effects. And so knowing what those look like and how they will affect your patient and the physiology of your patient, as well as the duration, the onset of the agent, and kind of the mechanism of the hypertensive emergency is also very important. So this table will be provided with the slides on the Learning Resource Center, so we don't need to go into the nitty-gritty of everything. So you can take some more time on your own to go through the details.
It's important, I think, for people to recognize what is the dreaded side effect from like nitroprusside? Anyone?
Well, maybe the most frequent is a secondary steal of coronary perfusion that can happen. For many of our patients, a wrong use of this medication without a correct assessment, or for example, an invasive arterial line, it's difficult. It's difficult to predict. Maybe we can. This is the most frequent secondary adverse events that we see in these patients.
The chat box is giving a lot of the answer as well. With cyanide toxicity. So a lot of people are talking about it in the chat box.
Yeah. So the other thing that, Freddie, that was an excellent point to make is the monitoring. So if we only have so we can talk about blood pressure monitoring, which maybe we should have done at the beginning of the webinar, but how do you monitor blood pressure? You can do it by feeling it, right? And see if like the patient has a blood pressure, but also you can do non-invasive blood pressure monitoring. And some of that is with a sphygmometer, where you actually pump it up and then you put the stethoscope on and you listen for the Khartikov sounds. Another type of non-invasive blood pressure measurement is an automated oscillometry, where it's a machine that does the blood pressure for you. But then oftentimes when we get into monitoring, with these patients, monitoring them every 15 minutes or every 2 hours or whatever, we have an invasive blood pressure monitor with an arterial line. So that's an excellent point. When you start to move these patients to the intensive care unit, and you have the ability to start an invasive blood pressure monitor, that is certainly the indication, because you want to keep a very close eye on them. So perfect. Thank you. What about this class of drugs?
This table lists some commonly available adrenergic inhibitors. And so these would be like your LULs, so your beta blockades. These agents are more commonly available in settings. It's important to also recognize with these the onset, duration, and side effects that you may see. So that's within the table. You can look and get, for esmolol, it's very quick on and off, so it's easily titratable. However, you can get some nausea, flushing, bronchospasm, which are commonly seen with a lot of the beta blockers, first-degree heart block. So it's important to understand these. The table, again, will be provided with the slides when it's posted online. So no need to like worry about squinting to see the letters and the words on it, but just have an understanding of what they all are and what they do to your patient.
And Dr. Komisky, you said these were the LULs. What does that mean? Esmolol, metoprolol, labetalol.
Yeah.
Is that what you
I
mean?
typically think of these as like the beta blockade agents, and so that tells me their mechanism of action hones into letting me know like where the effect of the drug will lead to. So the suffix will help me with that.
Perfect.
I have a question for Andrea and,
Yes.
and the rest of panelists. When you use labetalol at many patients, Do you frequently have the need to for additional doses of labetalol?
I typically will, usually in my practice, what I'll do is I'll order labetalol IV push up front while I'm waiting for, like in an aortic dissection scenario, for example, I'll do the labetalol up front while waiting for one of the titratable drugs like esmolol to arrive, since it will take a little bit longer. But if I only have labetalol available, then typically I'll have to do multiple pushes every so often. We also put it frequently on people's medication list for PRNs medication to get them off of IV drips. And so that'll help me understand what their true needs will be. If they're getting the PRNs every 4 hours as scheduled, then perhaps increasing the dose or adding another oral agent on would be more beneficial. So it helps me understand what the patient's needs for antihypertensive drugs are. But frequently I'll need more than one dose.
I'm telling this because we decided in my hospital, for example, to divide in pre-charged syringes by 5 to 10 milligrams of labetalol. So when you use it, you can experiment a necessity of more doses and titrate the final dosing of in these cases. Don't you?
I think what you're discussing, Freddie, is very interesting because if you have just a syringe with 5 to 10 milligrams, that may be adequate for some patients, but for other patients, you're going to be giving more than that. And I think Dr. Komisky's practice is similar to mine, in which you can give the dose, but if it doesn't work and you have to give additional dosing, then you need to be ready to increase that to whatever level you're comfortable, and then also be ready to add a second agent, because if the labetalol doesn't work for that patient to get the blood pressure down enough, then you may have to add an additional agent, such as hydralazine. It seems like labetalol and hydralazine are the most commonly available, which is also my experience. And why I asked Dr. Hans earlier about the metoprolol. I was surprised to hear that he has that more than labetalol. But I think the other thing to consider, two other things. One is cost. So sometimes it's more costly to have individual syringes of medications versus a large vial that you can pull multiple doses from. So that's one consideration for the hospitals. And then the other consideration is the clinical context in which we're trying to lower that blood pressure. So if it's for aortic dissection, where we really want to get the heart rate down first, and I think the way I think about that is every time that heart beats with a high blood pressure, that dissection gets worse and worse. So you really want to slow down the heartbeats or the heart rate. And then, so the clinical context of that may be different than some of the other ones. But yeah, that's a really excellent question. And I think it comes up with not just labetalol, but a lot of our medications, how we use them, and whether it's a syringe push versus an infusion pump or something like that. How is Rodrigo?
Oh, our friend Rodrigo, we are now friends with Rodrigo because we decided to use labetalol. Yes, current blood pressure is 180 over 100, and the confusion improving. This shows the value of timely but careful blood pressure control. But we need to continue with ongoing monitoring and reassessment, as is this crucial, don't you?
Earlier in the case, Rodrigo had chest pain, but we did all of the labs, we did all of the imaging, and we did not find myocardial infarction. We did not find aortic dissection. And so this may be a chest pain that could have been from anxiety, perhaps. Who knows? But it's good that he's getting better and he doesn't have any dissection or stroke, I think. So it's been a lot of information and many different ways to treat hypertensive emergency. So I just want to summarize for everyone. The definition of hypertensive emergency is not just severe hypertension, so systolic over 180 or diastolic over 120, but it's the severe hypertension plus acute end organ injury. We talked a lot about the neurologic, cardiovascular, and we touched on some of the renal signs and symptoms of end organ injury. So for neurologic, you can have the agitation, the confusion, the seizures, the vision changes, or nausea and vomiting for an increased intracerebral pressure. Those would be non-focal signs. You can also have ischemic or hemorrhagic stroke, which might give you a more focal sign, or PRESS syndrome, as Dr. mentioned. If you have an ophthalmoscope, you can look and see papilledema or hemorrhages, cotton wool spots, or those white spots that you can see on the retina. The cardiovascular signs and symptoms can be chest pain. That can be from a heart attack. That can be from an aortic dissection. Back pain, again, is often associated with acute aortic dissections. And if you have, heart strain or heart attack, then you can also have that congestive heart failure, which may give you some pulmonary edema and dyspnea. So you can have cardiopulmonary signs and symptoms as well. Dr. Kramisky did a great job sharing with us the overall approach to this hypertensive emergency. So you would want to lower your blood pressure really by 10 to 20% in the first hour, and then gradually down to your goal over the next 23 hours. So within that first day, you want to try to reach your goal. No benefit to going below 130 systolic. So you want to get that blood pressure down, but don't get it down too far, and don't lower it too quickly. So that's for most people with severe hypertension and end organ damage. So this may be like a patient who has severe hypertension and some renal dysfunction. For example, you would want to do this controlled lowering of the blood pressure within the first day, hours to day. But there are 3 conditions that are different where we might want to lower our blood pressure differently. The first is going to be the acute phase of an ischemic stroke. And for that, we don't want to lower it too quickly. We also need to decide if our patient can be reperfused with TPA or alteplase, or they have contraindications to reperfusion. So within acute ischemic stroke, you need to decide if you're going to be able to reperfuse that patient or not. So if they are a reperfusion candidate, try to get them below 185 over 110. But if they are not a reperfusion candidate because they have contraindications to reperfusion, then you want to get them to below 220 over 120, but not to drop it too far, because you might worsen that ischemia. Acute aortic dissection. Thank you to Dr. Garcia for doing an excellent explanation of our management of blood pressure with acute aortic dissection. We need to know whether it's the ascending aorta or the descending thoracic or abdominal aorta, whether or not it's a surgical emergency, which would be the type A Stanford classification. And we want to start by lowering the heart rate first. Remember, every time that heart beats with that high blood pressure, that dissection extends and gets worse. So you want to lower your heart rate with likely a beta blocker. And then you want to add some sort of vasodilator to get the blood pressure down. The systolic goal is 100 to 120. This is different than our systolic goals for others. Sometimes we will go down to 130 for some of our neurologic patients, but there's not really a reason to go lower than that. It does not improve outcomes. Acute aortic dissection is different. You do want to get that systolic down to 100 to 120. And then intracerebral hemorrhage, the patient's bleeding into their brain. So obviously you want to lower the blood pressure, but you also want to manage the increased intracerebral pressure and hemorrhage expansion as well. So we might want to lower these patients much more quickly than our general severe hypertension plus renal failure, for example. So this is the summary. I want to remind everyone that the Learning Resource Center, we mention it in all of our webinars, but I just want to make sure that everyone has access and understands that you can scan this QR code to get to the Foundations of Critical Care course on the Learning Resource Center. The Learning Resource Center is free, it's open access, anybody can use it, you can share it. Within each one of these webinars, all of the slides that you see and all of the resources that you see are uploaded to the course so that you can take them down. You can have this PowerPoint, you can use it for yourself, you can use it to teach others, you can use it basically for whatever you want. We create these materials to be free and open access so that everybody can use them. If you go into the LRC and you go to the Foundations of Critical Care course, you can then go into the time critical hypertension management, and you can see that we've also created a resource library. What do we mean by resource library? These are infographics, cognitive aids, things that you can use at the bedside in real time to help remind yourself of how to manage certain types of patients. This is an example of a hypertensive crisis infographic where it has the definition as systolic greater than 180 or diastolic greater than 120 plus end organ damage. And you can see the differences in the end organs that are affected. So you can have acute heart failure, acute ischemic stroke, myocardial infarction, preeclampsia or eclampsia, which we did not speak much about today, pulmonary edema, aortic dissection, acute kidney injury. And then it also reminds us of some of the medications that we can use that might be preferred in each one of those types of situations. This is another infographic about hypertensive crisis, which gives you the timeline. So for most people, it tells you how to decrease your blood pressure in the first hour to 24 hours, but it reminds you that in aortic dissection, it's a lot faster. In hemorrhagic stroke, it's going to be different, as it will be for preeclampsia, ischemic stroke, etc. So whether you're reperfused or not. So another thing just to help remind us of some of these goals. I think it's also helpful to kind of zoom out a little bit. We're talking about the very extreme emergency of high blood pressure. But we talked at the beginning of the webinar about the global impact or burden of hypertension. And we talked even a little bit about some of the chronic problems of having hypertension, such as renal dysfunction or left ventricular hypertrophy in the heart. So this is a good reminder of what is normal blood pressure, what is elevated, what is considered hypertension, and what is considered hypertensive crisis. And again, that definition is greater than 180 over 120. There's not a test. We're not going to give you a test, but hopefully you know now what severe hypertension is, that definition based on the systolic and diastolic. Also within the resource library, we have links to other really helpful resources. One is hypertensive disorders in pregnancy. So we did not have enough time today to talk about preeclampsia and eclampsia, but this is a really good summary about how to manage hypertension in pregnancy. We did not talk much about pediatric hypertensive emergency, but this is a good resource to talk about our pediatric patients. The guidelines from the American Heart Association are also listed here. And then there's one that talks about managing hypertensive crisis in the emergency department. And again, it has those really nice infographics that I showed you there. So with that, Rodrigo thanks you. I thank all of the panelists and all of the learners. We have 4 minutes left, so maybe we can go through some of the Q&A. Do we have, Dr. Comiskey, any questions and answers? I don't see.
We had a couple that were already answered.
Okay.
One of the big questions that kept coming up, and Dr. Kirsch did a great job of answering, was asking about when to start PO oral agents for hypertension management, especially when it comes to like stroke patients. So I'm curious what Dr. Garcia, Mohar, and Arisa have to say about that as well with managing these patients.
Dr. Garcia, when would you start oral blood pressure medications?
Okay, for all medications, I think that definitely we are out of emergency or urgency, or sorry, just out of emergency hypertension. Maybe in cases of urgency, we can use these blood pressure medications oral. Maybe we can take the same medication that our patients are taking and optimize the drugs, the doses that they are receiving. But definitely, if we are in an emergency, we can't use oral medication. We can go with IV, as we told, with all the options that we have to control the heart rate or control the blood pressure.
Yeah, I completely agree with Hans. the key results, the key results depending of how do you know well to manage the medications. You can have too few medications, but if you can manage correctly and know the limitations and what are the correct indications, you can manage initially a case of severe hypertension before transfer the patient to the center with all the commodities and facilities for complete management.
I think a lot of it also depends upon availability. So if that's all that you have and you don't have the IV medications or an ability to use titratable infusions, then you should certainly use your oral medications. But in a setting where you have the oral medications and you have the IV medications, then you should try to reach those blood pressure goals in the time frames that we mentioned.
I think the problem we have to fight with these administrative problems that we have in our hospitals, because we don't have 1 hour to control an aortic dissection or a stroke or an hemorrhagic event. So we need to control quickly the blood pressure, and another medication is going to take 1 hour and maybe more. So maybe we need to fight. I think that sometimes ICU, emergency, anesthesia, we are really quiet compared to surgeons. Surgeons are asking for anything they want and they can get whatever they want. I think that we need to fight for our patients.
I love that. You're a very good advocate for your patients, Dr. Garcia. I have a question for you. If you have a patient that has hypertensive emergency and a confirmed myocardial infarction, what would be your priority? How would you manage this patient? Would you try to reduce the blood pressure or manage the MI, or both?
Yeah, sure. I think that we need to control both of the options, the heart rate and the blood pressure. Definitely the heart rate we need to decrease, because the heart rate is related with the oxygen consumption. So we can get 60 or below is going to be good for the heart. Decreasing the consumption of oxygen is good, but we need to guarantee to maintain the coronary perfusion. So we need to control the blood pressure. So usually beta blockers is the first option, but maybe at the same time, nitroglycerin is going to be the best option in this kind of patient. Nor, I don't like to use in these cases nitroprusside, because maybe we can complicate the coronary perfusion. I think that that's the best option that I have. I don't know the other colleagues.
Yeah, I think if you have high blood pressure and you have an acute myocardial infarction, the blood pressure is certainly going to strain the heart more, but by treating the myocardial infarction with beta blockers, that might actually already start to bring your blood pressure down. But if you try to use the beta blockers and the nitroglycerin to relieve the symptoms, in addition to your antiplatelet agents or heparin infusion, whatever you're using, then if you still have hypertension thereafter, then you may consider treating that additionally. But oftentimes by treating the myocardial infarction, your blood pressure will also improve by using those agents. Another participant is asking, is it possible to have a normal systolic blood pressure but an elevated diastolic pressure? What do our panelists think about that?
Well, usually I think that we can find that kind of blood pressure maybe in some patients that they have stiffness of the aortic arch. So maybe we can find these patients with systolic hypertension or diastolic hypertension isolate. Usually it's related with this pathology. It's completely different when we have a higher systolic blood pressure and a lower diastolic blood pressure. We need to think maybe in aortic insufficiency or something's wrong with the aortic valve. Yeah. But usually high diastolic hypertension is going to be maybe in older patients. I think so.
Yeah. So I think what we're talking about really is the pulse pressure, or the difference between the systolic and the diastolic pressure. And like you, Dr. Hans, I think about when that pulse pressure is wide and that diastolic is very low, I think about aortic regurgitation or insufficiency. When that pulse pressure is quite narrow, I think first, because of mostly I do medical intensive care, then I actually think of that narrow pulse pressure as like a hypovolemia or like a septic type picture. You might have a very narrow pulse pressure, but if the systolic is normal and the diastolic is higher, then like you, I think this is maybe a problem with the aortic stiffness. Yeah. So I think the same. Anyone else think about things differently with the pulse pressure? The other thing is to think, are you using a non-invasive blood pressure cuff, or are you using an arterial line? If it's an arterial line, is it calibrated and positioned normally, correctly? Yeah, yeah. Okay, I think we should call it there. We are 4 minutes over. So we would love to talk to you all day. We really love seeing all of you. Thank you for joining us again. And thank you to my amazing panelists. So we had a very heavy Latin American presence today, which I love. But we'll see you again next month. Next month, we're talking about oncologic emergencies. So it should be very interesting. Having emergencies with cancer patients is sometimes due to the cancer itself, but oftentimes it's due to the treatment of the cancer. So we're going to talk a lot about different syndromes, treatment complications, and cancer complications next month. So we hope to see you all again. Thank you very much. We love seeing you. Thanks for all the lovely reactions and smiles. It's like fireworks. It's when you see all the reactions, it's like
Yeah.
it's like in the United States, we celebrate the 4th of July for the birthday of our country, and it's like the fireworks. It's really nice.
Happy day.
Have a good day. Bye.
Thank you, everyone.